Hello, everyone. Welcome to the Girlfriend Doctor Club. I'm excited to have you guys here, and I have a special guest here today who's been a longtime friend. And I'm excited to introduce her to you as we hit on our topic of oral health today and how it relates to cardiovascular health, how critical oral health is for overall physical health in general. And, as an OBGYN, we always say, okay, poor dentition or gum disease is a risk factor for miscarriage and infertility and these other factors. But there's so much more that we're learning about oral health and the oral microbiome that I'm excited to share with you today. So without further ado, I want to introduce to you my good long-term friend. Her name is Dr. Ellie Campbell. Well, I first met Ellie when I was Ava Marie. So 17 years ago, Ava Marie was just like a couple months old. I was still breastfeeding her and I was lecturing in Atlanta. And here there was a person in the audience and she was, there with her questions and her inquisitiveness and, like on the, again, decades ahead of other colleagues. And I was like, oh, this is going to be a lifelong friend. And she has been. So Dr. Ellie Campbell is originally a Metro Chicago native, and she graduated from the University of Illinois. She obtained her master's in 1984 and her osteopathic medical degree in 1989. She has been in private practice in Georgia, working in family medicine and also educating nationally and internationally in this topic. She recently wrote the book called The Blood Pressure Blueprint and has had dove into oral health and its relation to cardiovascular health. So welcome, Ellie. Good to have you here.
Thank you, Dr. Anna. It's so my honor. I'm so sorry we're not in person together. We have not gotten together in the same room to snuggle up
Been
and
too
talk
long.
and talk till wee hours of the night like we used to when you lived in Georgia. So I do miss you, and thank you for having me for your audience. I am a hardcore family physician for almost 35 years now. But 20 years ago, I shifted into more functional medicine and more root cause resolution. And even as I did that, my patients continued to suffer from the number one killer in our country, which is cardiovascular disease. And when one of my dearest patients suffered a stroke that took her life, even though I was following the best evidence-based guidelines for managing high blood pressure and high cholesterol and hormone replacement, I was doing all the right things. She had a stroke anyhow. I felt cheated. I felt like somehow my system had failed me, and there had to have been something that I missed, something that I didn't know then that I needed to know if I was going to preserve her life. And it turned out that thing that I missed was her oral health, not knowing at the time that she was suffering from a dental infection and had a tooth extraction procedure scheduled for the week after she died from a stroke. Had I known then what I know now, I would have been doing leading indicator tests in blood, urine, and saliva that would have given me clues months or even years before she had this event that her oxidative stress wasn't under control, her insulin resistance wasn't under control, her inflammation wasn't under control. And when we add to that the match of a tooth infection, it ignites a blood vessel rupture that causes this sudden event. So heart attacks, I believe, are optional and strokes are stoppable if the patients are willing to get the tests and do the work. And a lot of that work is therapeutic lifestyle changes that we talk about all the time. It doesn't matter if you're suffering from hot flashes or diabetes or cardiovascular risk or rheumatoid arthritis or lupus or whatever. We have to eat clean food and drink clean water and exercise and pray and meditate and spend time in nature and have a purpose in life and be connected to our community. If you don't have those fundamentals right, nothing else that I do is really going to have as much of an impact. So we start there, of course. But oral health is connected now to at least 56 other systemic illnesses. Somewhere along the way, the American Dental Association and the American Medical Association split off, and never the twain shall meet. And they decided that somehow the mouth was no longer connected to the rest of the body. And we have dentists that take care of the mouth and medical doctors that take care of everything else. And that's a false paradigm that leads to the number one killer in our country staying the number one killer in our country, despite spending billions of dollars every year trying to reduce it.
Yeah,
So
and Ellie, so I mean, with that said, I mean, it does high blood pressure. We typically relate to men's health, but it is like you said in your case, but you know, in your patient story. I mean, it's a silent killer of women too, and it's been, I would say, not mismanaged or improperly managed. And again, the key aspects to look for are often overlooked. You've mentioned, and you wrote in your book, The High Blood Pressure Blueprint, you talk about key tests to measure, key testing aspects. What are some of those key tests that aren't hard? And we have done, and we'll put a link or in Jami will email out the link to the podcast Dr. Campbell and I did on oral health. We've done a few podcasts. So the one we did on oral health with Bristol Health is a diagnostic that goes really in depth in it, but we'll put some of those links in the follow-up email.
and so I think what you said is so true. Cardiovascular disease is the number one killer of women, not just men. We worry about our breasts, but in fact, 10 times more women will die from cardiovascular disease than die from breast cancer. So we really need to put it front and center on our radar. And in some cases, I hate to use the word gaslighting because I think that's maybe too strong of a word, but the problem is that historically, most of the clinical research is done on males. And it doesn't translate evenly to women. Our blood vessels are smaller. They react slightly differently. They're more hormonally sensitive to our estrogens or lack thereof. And so we don't respond in the same way. When a man has a heart attack, pretty much everybody in the room knows it. It's very dramatic. He clutches his chest. He breaks out in a sweat. His eyes are bulging. He is feeling nauseated. He might throw up on his shoes, and he's got this crushing chest pain and this feeling of impending doom. And he goes, "I'm having a heart attack. Call 911," right? When a woman has a heart attack, it's often, "I don't feel right. I used to be able to vacuum this whole room, and now I can only vacuum 3 stripes and have to sit and rest. I'm very fatigued. Feel a little queasy in my stomach. I just feel a little hot." It's not dramatic. It's very subtle. And so when we go to the emergency room with those symptoms, they're often ignored. One Christmas Eve, I had a patient who had recently broken up with her boyfriend. And by the way, depression is a risk factor for heart attack. Recently broken up with her boyfriend. It was New Year's Eve. She drank almost a whole bottle of champagne and a whole bag of Cheetos all by herself in a pity party because she'd broken up with her boyfriend. And it was New Year's Eve and she was by herself. She called me New Year's morning and she goes, "I don't feel right. I'm very queasy. I'm just a little bit short of breath. I try to go and do some house chores, but I'm just too tired." I said, "You get your butt to the emergency room right now." And the nurses laughed at her. They called her Cheeto Girl. And they said, "Nobody can expect to eat a bag full of Cheetos and not be queasy the next morning, can they?" And it turned out she had a small heart attack. Only because I told her that that's what she needed to be checked for did she say, "I'm not leaving here until you've done the right tests to make sure I'm not having a heart attack." And nobody could believe that it was true. But everybody should have known. These are healthcare professionals in the emergency room. They should have that checklist of women's symptoms. They're different than men's, and they're listed in the book. So what leading indicators can we use to help us decide if that's going to be us or not? Well, one thing is blood pressure, right? We want to keep our blood pressure in target, and the target guidelines keep dropping. When I was in school, 160 over 100 was acceptable for a senior citizen. We now know that that is seriously dangerous high blood pressure. And I was in fact taught that if that's a senior citizen and you try to get their blood pressure normal, you're going to make them weak, dizzy, pass out, and they're going to fall down and break a hip, and it'll be your fault because you treated their blood pressure. We now have clinical studies to show that that's not true, and that was a medical urban myth. We don't want to drop it in one day to normal, but we want to gradually, slowly get that patient to target blood pressure. What is normal? Normal blood pressure is now defined as 119 over 79 or less. 120 over 80 is now considered elevated blood pressure. And if you have high blood pressure, we want to treat you to normal. We don't want to treat you from high blood pressure to high blood pressure. We want to treat you from high blood pressure to normal. So you really want to try to get there down around 119/79 or even a couple points less. The average person, that's going to take 2.3 blood pressure medicines to get there. But the average person doesn't see a functional medicine doctor and doesn't have the root causes identified as to things that they can do on their own by themselves that don't require a medical
And
doctor.
Ellie, to clarify, 119/79 for both men and women?
Men and women. Yes, ma'am. No gender difference here. And in Europe, the European guidelines for hypertension just came out. In Europe, they dropped that 80 to 70. So in Europe, you're considered to have an elevated blood pressure, 120/70 or higher.
Now let's go into this, because when you go into the doctor's office, there's the often white coat syndrome. So
Right.
when should we be looking at this number when we're looking at, okay, what is my blood pressure? Is it like right when I rush into the doctor's office, or when I'm standing in line at the pharmacy or wherever they're doing blood pressure? I mean, when should we do it?
Right. Well, first of all, most doctor's office, including mine, I'm ashamed to say, until I dove into it to write this book, measure blood pressure wrong. There are several errors that are made, and we are trying to standardize what a normal blood pressure is so we can compare apples to apples to apples, whether you're having your blood pressure checked at the cardiologist or the primary care or the eye doctor or the dentist or wherever, who's ever checking your blood pressure, you want it to be checked the same. The first thing, 5 minutes quiet, no talking, not even active listening. That can jack your blood pressure 10 points if you're chit-chatting with the nurse who's checking your blood pressure. Next, we want to make sure that you are seated properly, bottom to the bottom, back to the back, feet on the floor. I have a problem. Unlike Dr. Cabeca, I am 5 feet, 0.6 inches tall. I cannot sit on most chairs with my bottom to the bottom and my back on the back with my feet touching the floor at the same time. My feet dangle. When that happens, I must be offered a stool to rest my feet. I've never been offered a stool in any doctor's office ever. And they're not following the guidelines in order to check your blood pressure properly, because having an unsupported back can raise your blood pressure 10 points. Having unsupported feet, 5 to 10 points. We don't want to do that to our patients, accidentally giving them hypertension just because we're measuring their blood pressure wrong. Another thing, the most important trigger, one of the highest triggers of blood pressure is having a full bladder. In my office, our protocol used to be the patients were taken from the reception area, we don't call it a waiting room, from the reception area to the exam room to get their blood pressure checked. Meanwhile, everybody's chit-chatting all along the way. How are you? How are your kids? How was your vacation? Did you have a good time? Right? So we had this chit-chat stuff. Sat the patient down right away. We didn't give them 5 minutes to rest. Slapped the blood pressure cuff on their arm, often while they're sitting on the exam table with their feet dangling. Checked their blood pressure, got their vital signs, and then said, Dr. Campbell's going to want a urine specimen. Please walk down the hall, give a specimen, and write your name on the, put in the window behind the toilet tank. Having a full bladder can raise your blood pressure 15 points. We changed our policy. Everybody, the minute they hit the reception room, is now walking to the bathroom to empty their bladder, come back, sit quietly, no talking, and then they get their blood pressure checked. And the other common mistake is having the wrong size blood pressure cuff to measure your blood pressure with. We know it's pretty obvious not to put it over a winter coat or a sweater, but even a t-shirt can raise your blood pressure 5 or 10 points. A sweater, 40 points. I don't know how many sweaters they wear in Dallas, but in Chicago, where I come from, people usually came to the office in a hoodie or a sweatshirt. So we can't measure their blood pressure over that thick clothing. It can give 40 points of false blood pressure reading. And most of us who go to the gym to work out get these really big biceps. And if you use the wrong size blood pressure cuff, you can jack their blood pressure by easily 20 points. So the normal adult size blood pressure cuff is too small for my arm. But the thigh cuff is too long for my short arm because I'm only 5 feet tall. So there's an in-between size that most offices don't carry, but we ordered and have now, and it's now our most commonly used cuff. It's called the Welch-Allen Adult Long Blood Pressure Cuff. It's the same width as a regular blood pressure cuff, but it's longer to get around those big arms. And that will give you a proper blood pressure reading. So those are 7 mistakes that many doctors make, including me. So when we standardize our blood pressure numbers, now we have a better idea. Many people do have a white coat phenomenon. Up to 20% of patients will have a blood pressure startle response that gives them 15, 20 points more blood pressure than they really have. This is where home blood pressure monitoring comes into play. And I would never treat a diabetic and tell them how much insulin to take based on one reading of a blood sugar that I did in my office one time. I would never treat a blood pressure patient based on one reading of a blood pressure that they got in my office one day. So if you have white coat hypertension, you should be leaving the office with a prescription for a home blood pressure cuff and frequent blood pressure monitoring at home that you will then send in by fax or email or portal or however your doctor wants it, so that I can get 10 or 20 readings from home. Like son-in-laws, right? Potential son-in-laws. You want to know what they're like on their best behavior, but you also want to know what they're like when they're underslept, overwhelmed, frustrated, hungry. What are they like then? That's what I want to know about your blood pressure. What's it like on your best day? What's it like on your worst day? How good can you get it? How bad will it go? And then I have some data to work with. And then I can figure out if you should be dosing your medicine in the morning or in the evening. Should you be dosing every day? Should you be one of those very rare patients that only takes medicine once in a great while when you're overstimulated? So there's another syndrome called masked hypertension. And these are people who are so good at getting in their zen when they go to the doctor's office that their blood pressure is totally normal. But at home, they have high pressure readings. And so that's called masked hypertension. It's kind of the opposite of white coat hypertension. And in both cases, we need home blood pressure readings to get us a bunch of data so that we can make decisions over the long haul.
And so do you recommend a specific digital blood pressure cuff? And then we're looking at that one, and also when we're looking at that 119/79, is that an average because it's going to fluctuate throughout the day?
Yes, that's your general average.
And that's when we're looking at that 119/79. That's our optimal blood pressure in optimal conditions in general too. We can get it that low. If we have high blood pressure systemically, it's going to stay elevated.
We're going to try really hard to get it low. And usually you're not going to get it there with medication alone. You're going to have to do the work, right? And there's some hidden secrets in functional medicine that we are well aware of that conventional medicine doctors often overlook. For example, low magnesium levels. Many, many patients, probably the number one nutrient deficiency that I see in my practice is low magnesium level. And even if you look at the blood reference range for magnesium, I want my patients in the upper third of that reference range, somewhere around 2.2 to 2.4 for most people.
Ellie, I look at red blood cell magnesium and not serum magnesium.
Yeah, so many functional medicine doctors will look at red blood cell magnesium. I was testing red cell magnesium for a while, and I think it's a valuable tool, and I don't disparage anybody who uses it. I use serum magnesium because I find that if I keep it in that top third, that almost always their red cell magnesium will be adequate and I don't have to spend the money on the extra test. So I think it's still a good test to use. I don't think it's critical to get a red cell magnesium. And when a person is magnesium deficient, it's very hard for them to hold on to potassium, vitamin D, calcium, and other nutrients, zinc. So we have to replete magnesium first. And I've helped many people get off blood pressure medicine simply by giving them a magnesium supplement. Many people are told when they have high blood pressure, you eat too much salt, you're very salt sensitive. But they never did the test to see if they really are salt sensitive. And in our experience, most patients who have adequate magnesium and adequate potassium are not really salt sensitive. It's just that the salt manifested a problem when they were deficient in those other two nutrients. So how do you know? Well, you take yourself off of salt, you put yourself on a very low salt diet, less than 2 grams of sodium for a week or two, and you check your blood pressure. Make sure you're getting enough magnesium and potassium. And then for 2 weeks, you put salt on everything and you compare how did your blood pressure do off salt and on salt, and only about 20 to 25%.
Or we talk about different types of salt. We're not talking about iodized table salt. We're talking about Himalayan sea
Healthy
Celtic
pink,
salt,
gray,
mineral salt.
Celtic
Yeah,
sea salt, Mediterranean sea salt. And if your blood pressure doesn't change, you're not salt sensitive, and you can tell your doctor, I did the experiment. My blood pressure was the same off salt and on salt.
that's a great tip. Yeah.
I don't think I need to restrict myself from the flavor of food just because you think I might be salt sensitive. Let's do an experiment and prove it. So let's see what else. So those are some, one of the leading causes of cardiovascular disease in women is untreated hypertension.
Yeah.
One of the hidden causes of hypertension in women is undiagnosed sleep apnea. If you at night are snoring, are restless, are flipping over in the bed, wake up unrefreshed, wake up with a dry mouth, bad breath, foggy brain, you must get a test for sleep apnea. Sleep apnea is a condition whereby
There are at-home tests you can do now. We used to have to send clients, we had to write prescriptions to sleep studies. Are those at-home tests good, Ellie?
They are better than nothing. An at-home oximetry reading where you're just measuring your oxygen level is pretty good. The at-home tests that are written by a prescription, like by the company called Itamar, a company called WatchPat, or the test is called WatchPat, extremely accurate, but they still have to be prescribed. We're getting to the point where there's more and more over-the-counters available. Some of the wearables you have to be careful with, but in the condition of sleep apnea, apnea means lack of breathing, no breath. And so at certain times during the evening while you're asleep, you stop breathing. Your brain, your heart, your lungs, your sex organs, your arteries are choked for oxygen. There is no air going to those organs, and they get very stressed. And they react to that stress by clamping down the blood vessels, trying to get extra blood squeezed up to your brain. That causes hypertension. I now have 6 different treatments for sleep apnea besides a CPAP mask. Many patients will refuse to be tested for sleep apnea because they think the one and only treatment is a mask with an elephant trunk tied to it for the rest of your life, and that's not true. We have lots of different treatments. We have everything from nasal splinting and lip taping to body positioning to oral dental appliances to oral myofunctional therapy, which is like physical therapy for your jaw, lips, and tongue. And in some cases, surgery called MMA, maxillomandibular advancement surgery, where it's a big deal. It's a big surgery. Don't want to make light of it, but they cut your jawbone, your cheekbones in half, your jawbone in half. They put bone grafts in and pull your entire face forward, half an inch or so, making room for your tongue and your airway. It's 95% effective in permanently curing sleep apnea, and it's covered by 95% of medical insurances, and no CPAP is required. So it's a big surgery. It's a big deal. And then
you get a facelift at the same time. I mean, heck,
yeah, it kind of does a facelift.
Surgery, right? All right, so we've hit on blood pressure, sleep apnea, and is some of the key, causes of this high blood pressure. And one of your main areas of focus is oral health, tying
Right.
into oral health. And so certainly sleep apnea issues tie in. Mouth taping has been shown to reduce gingivitis and cavities, things like that, increase deeper restorative sleep. What are making that connection with oral health is a really big deal.
Yeah, it's a big deal. So there's a couple of things. First of all, we're supposed to have a microbiome in our mouth, just like we're supposed to have a microbiome in our gut and in our vagina and on our nose, on our skin. Every part of our body has a microbiome. The problem is if the pH is off, especially if the pH is acidic, the wrong bacteria are favored. And we tend to get a shift in the oral microbiome, getting oral microbial overgrowth. And when you get these bad bacteria in your mouth, several things can happen. Cavities, gum disease, bad breath, and most importantly, the bacteria that cause the gum disease can get in your bloodstream, in your lymphatics, and climb up and down your trigeminal nerve and your vagus nerve and spread everywhere else in your body. What happens in the mouth doesn't stay in the mouth. And those mouth bacteria have very aggressive virulence pathways that they use to cause real trouble other places in the body. For example, Porphyromonas gingivalis makes a wax. It secretes something called phosphorylated dihydroceramide. It's a wax. Well, that makes sense if it's on your teeth, right? It's going to make plaque. But what happens is that PG bacteria hitches a ride on red blood cells, gets into your brain, and makes plaque in your brain. We call that Alzheimer's disease. So mouth bacteria can cause Alzheimer's disease. Taking care of your teeth and gums means taking care of your brain. Taking care of your teeth and gums means taking care of your heart. FN bacteria, one of the bad guys in your mouth, the pathogens, has been shown to cause colorectal cancer. So we don't want to have these bad bacteria in our mouth. And pH is one important factor. What causes your mouth to be acidic? Mouth breathing, dry mouth. So you don't want to have a dry mouth. That's part of why lip taping, simply using micropore tape to seal your lips at night before you go to bed, can increase the salivation, keep the saliva in your mouth, not let your mouth dry out, increase the pH, make it less favorable for those bad bacteria. People who have chronic disuse nasal atrophy can't do this. They can't tape their lips closed because they'll suffocate. Their nose is so clogged and so stuffy that they can't breathe through their nose. That's because your nose forgot how to do its job. We have to retrain it. So for these people, we will have you tape your lips closed at night. Tape your lips closed during the day while we're watching TV or while you're playing a game on your phone. Do it for 20 or 30 minutes. Practice breathing through your nose during the day. When you can get to the point where you can tape your lips closed for 4 hours, then you should be able to go all night without worrying about it. Some people need to put little splints up inside their nose to dilate their nostrils to get enough airflow. Some people have to use Flonase or Nasonex, a steroid nasal spray, to reduce their symptoms. Some people have food sensitivities. They need to get rid of those foods that are causing the nasal stuffiness. Some people have mold exposure. We need to get rid of that. There's lots of underlying causes of nasal stuffiness we need to get under control so that you learn to breathe through your nose, because noses are for breathing and mouths are for eating. We
And
don't want to
dairy
breathe.
is a big causes a lot of mucus production. So eliminating dairy too, if that's an issue, can make a huge difference.
Absolutely. So we got to breathe through our nose. That's so important. Also, another important part about nose and mouth connection. There's a miracle mouth molecule that won the Nobel Prize. It's called nitric oxide. It's a gaseous signaling molecule, and it regulates blood pressure, blood sugar, immune system. It's got hundreds of downstream pathways that nitric oxide is involved in. The number one place where nitric oxide is made is in the floor of your sinuses. So you have to move air in and out to be able to do this. But there's an enzyme called nitric oxide synthase. And this is in part, if this is deficient, you cannot make nitric oxide. The mouth bacteria convert nitrate to nitrite to start this pathway going. You have unhealthy mouth bacteria, you can't give your nose what it needs. Isn't that fun how God put our mouth and our nose right connected to each other so that our mouth sets it up like a volleyball, and then the nose slams it down like a dunk, right? So we've got these intricate connections of how to make this miracle mouth molecule that will open our blood vessels and lower our blood pressure. And it all happens because of our mouth and our nose being connected.
And then testing for oral bacteria. One of the things that in our podcast, and we'll link that, is the Bristol Health Test, looking at different types of bacteria. How are you using that in your practice?
Yeah. So we now know that we're starting to name names, right? We now have the names of these pathogens that have particular virulence factors that lead to what one causes cardiovascular disease, another one causes cancer, another one causes brain damage, Alzheimer's, et cetera. So there's probably 9 major bacteria that are in our mouth, not to mention yeast and viruses that cause this pathogenic shift. They're called red complex bacteria. Sadly, most dentists and most periodontists don't check for these bacteria yet. We're trying to shift that because the science is caught up with us now. And we know that if you have these bacteria, these red complex bacteria in your mouth, there's like a 30% chance that your root canal or implant is going to fail if you have surgery. So we want to double check and make sure that we're testing. Bristol is one of the over-the-counter tests. Bristol's a good test. There's a couple of things I don't like about Bristol. Number one is that it only measures relative abundance. So it doesn't give me a quantitative number. It just says you have more A than B bacteria. And A is a pathogen, so we don't want it in there. We want B to be higher. But it doesn't tell me if I have a little bit of these or a lot of these. It just tells me relative one to the other. The other thing about Bristol is they throw a really wide net and they check hundreds of bacteria. We don't know what the significance of all those hundreds of bacteria is. So it's a really long report. And a lot of the data, I think, is weeds that aren't as relevant as the nuggets of the important 9 types that we know the literature supports highly impactful to our systemic health. I think that research is coming out. Bristol has scientific evidence to support what they do. I am not saying it's not a bad test. It's a good test. But I think that we can get as much information, we can move the needle on our oral health with a little subset of that information and not have to have all that noise in the background contending with the important information. If you have certain bacteria, the traditional treatment at the periodontist is root scaling and planing, deep cleaning. The 3 most aggressive bacteria are completely resistant to that treatment. It doesn't help clear them away. That's why I have to go back to the periodontist every 3 months and keep doing this treatment over and over again. We need to start looking at what the science tells us is better treatment for these. And that may involve laser rather than root scaling and planing. That probably will involve very targeted antibiotic use. If antibiotics were the cure for periodontal disease, Americans would have the healthiest gums on the planet, right? We take more antibiotics than everywhere, and we still have rampant periodontal disease. Up to 80% of all diabetics will have it, and up to 50% of people over 50 will have it. So it's a huge infectious disease problem, periodontal gum disease. So antibiotics are not the only solution. And if you're going to use antibiotics, they must be treated within 4 hours of any dental procedure that you have, or all the bad bacteria recolonize. So most dentists, even if they're using antibiotics, don't time the antibiotics properly. You got to get the antibiotics in at the right time with the cleaning. So that's important. We also know probiotics play a role, and there's specific oral chewable probiotics that you can use that chase away the bad guys and keep the colony counts of the friendly bacteria higher. There are natural antibiotics. There's colloidal silver, there's iodine, there's grapefruit seed extract, and different bacteria respond different ways, and different clusters of bacteria behave different ways. So you have to work with an experienced hygienist who has training in this to know specifically your pattern of bacteria, what treatment. If you're going to use iodine, you better make sure it's the kind of bacteria that are that respond to and are killed by iodine. Otherwise, you're just exposing yourself unnecessarily to higher doses of iodine than you need. And that can be dangerous to your thyroid. So risks and benefits for every treatment. You're muted, Anna.
What about ozone, oral ozone or injectable ozone?
Yeah, I think oral ozone, injectable ozone are great therapies, and we're starting to learn more and more about how we can utilize this super oxygen as a sterilizer. We never want to sterilize our mouth. It's supposed to have a microbiome. I don't want you using napalm in the inside of your mouth to kill every bacteria. I don't want you using Listerine to wash away every bacteria, because it's supposed to have a healthy, friendly microbiome. And if we clear away all the good guys, the bad guys are going to come in first. That's well established. So what we really want to do is be targeted in any use of antimicrobial therapy, targeted even for ozone. I think that when we have a root canal, ozone is a super helpful treatment to reduce the risk that you're going to have a complication related to that root canal and preserve it for as long as possible without getting a secondary abscess that results in the tooth having to be pulled, which is what you were avoiding the whole first time around. Why you did a root canal to begin with was to try to prevent that tooth from getting pulled.
So how are you testing then for those top 9 pathogenic
Spit
bacteria, oral
test.
bacteria?
Yeah, so there's
Spit-
several companies on the market. Simply Perio is one that I use. Oral DNA is one that I use. I used to use one called HR5, but that company's closed, no longer in existence. But it's a simple spit test. Some of them you dump some salt water in your mouth, rinse and spit into the cup. Some of them are just straight up saliva. And we send it off to the lab, and in a week or so, I have a report that tells me what bacteria you have. Do you have bacteria that putting you at risk for cavities, for implantitis, for gum disease? I had a cracked tooth. When your tooth cracks a root, the tooth is goner. You can't save it. You can't crown it. You can't root canal it. The tooth has to be pulled. So I had a tooth pulled. It was a very traumatic experience. I felt like I had a body part amputated. And honestly, I'm still grieving a little bit over the loss of that tooth, because I take better care of my teeth than any other part of my body. They get more attention. They get brushed, they get flossed, they get water flossed, they get rinsed, they get gum treatments, and I still lost a tooth. So I did a spit test, and I found out that I have 4 of the top 9 bad bacteria in my mouth. I have no bleeding on probing. I have no gum disease. I have no deep pockets. I have no sign of gum disease. I'm told my gums are very healthy. And yet I know that if I'm going to replace this tooth with an implant, I have a 30% chance of that implant being rejected because I have these bad bacteria in my mouth. So I am proceeding now with a fairly aggressive treatment protocol to try to eradicate those. And that includes using ozonated toothpaste, so that I can clear those bacteria away, so that I will be a candidate to have an implant replacement for that tooth that I cracked. So, but if I didn't know it, I would just jump into the periodontist chair. He would make me an implant, and I would go ahead and do it, not knowing that I just spent whatever this is going to be, $8,000 at risk for having to be done again in a couple of years because it failed. And I don't want to have to do that if I don't help it. Not to mention the fact I ain't got time to do that procedure twice. Once is big enough.
That's right. And also oral enzymes. So chewable probiotics and chewable enzymes. I think those are really good. I mean, I had the experience with that when Ava Marie, when she was a baby, she had just, a lot of the milk cavities from falling asleep nursing and me
Right.
being exhausted and just letting her. And so she
Well,
had,
and to be fair, it was bacteria that caused those cavities.
yeah,
And you didn't
totally.
know that
Right.
those bacteria lead to the production of organic acids, and the acids eat the cavities in the teeth. So we're trying to use enzymes to disrupt that pathway some. But if you'd known that she had specific bacteria that you might have had a targeted treatment protocol for, things might have been different for her.
Well,
We
and we
didn't know
switched to,
then.
right. We didn't know 17 years ago, but we are 16 at that point, but using oral chewable probiotics, really eliminated that. And then she would have clean dental issues. The other thing too is the oral chewo probiotics. If your doctor says, oh, you've got 3 millimeters or more between gum and toothpaste or whatever, 4 millimeters, 5 millimeters, however they grade those, and they want to do that scaling procedure, start with the enzymes and oral probiotics first, and let's see.
And an electric toothbrush, a water flosser, a string floss that has charcoal and or xylitol, because the charcoal helps to neutralize the pH some. So you use a charcoal colored floss, it can really help to get rid of some of those little nests of bacteria in between the teeth. There's
And
also some,
remineralizing toothpaste,
yes,
remineralizing toothpaste. And what
yeah,
about
hydroxyapatite,
charcoal toothpaste as a option?
all of those options.
Yeah.
The xylitol is a really interesting story. Now, xylitol is a polyol. It's a natural sweetener that humans make, that many trees, including birch trees, make, plants make. It's a natural sweetener. Never give it to your dogs. Anything that's got xylitol in it can kill your dog, so keep it away from canines. But for humans, it's really a helpful molecule. When pregnant women were given xylitol 3 times a day to 5 times a day during their second and third trimester of pregnancy, their babies had 80% less cavities through age 5. So when we change the mom's microbiome in her mouth, and she kisses her baby and she sucks the pacifier and gives it to her baby, she has changed her oral microbiome for the better, and it helps the kids through age 5. All pregnant women should be using 5 touches of xylitol a day. 2 can come from your toothpaste, and then 3 from a gum, a mint, a chewy. They make little tiny xylitol finger cots that you can wipe your newborn's mouth with after you nurse. They make xylitol spray you can spray under their tongue. They make gums and mints and chewies and gummies and all kinds of xylitol. We want to get 5 touches of xylitol a day. It's good for us. It's good for our microbiome. In one study of children with autism, they shifted their microbiome by getting them on regular xylitol and probiotic, and 5 children regained the ability to speak just by changing their oral microbiome.
Mm,
Your
amazing.
brain is connected to your mouth. Your stomach's
Totally.
connected to your mouth. Your heart's connected to your mouth. Your intestines, your gonads, every
Your
part of
womb,
our
right.
body. Your womb is connected to our mouth.
Yeah. So Ellie, tying in, okay, looking at oral health and blood pressure and cardiovascular disease, what are some other biomarkers that we want to look at?
Yeah, so besides the salivary diagnostic test, there's markers of oxidative stress and inflammation that are blood and urine. And I'll rattle them off because they're big, long names. These are commonly done by labs like Berkeley Heart Lab and Cleveland Heart Labs and Quest Diagnostics through their Cardio IQ program. LabCorp does them as well. The labs are called myeloperoxidase, LPPLA2, that stands for lipoprotein associated phospholipase A2, galectin-3, proBNP, oxidized LDL, high sensitivity C-reactive protein, and there's one more, F2 isoprostane. So these are markers in blood and urine that tell me that your body is on fire on the inside, that you have a high amount of oxidative stress. And there is, for example, myeloperoxidase is an enzyme. It comes from activated white blood cells. White blood cells who are fighting an infection, myeloperoxidase is made by those white blood cells. What we know is that oxidized LDL, that when cholesterol becomes corrupted, LDL cholesterol is the bad cholesterol. When it becomes oxidized, it acts as if it's a bacteria to the white blood cell. It causes that same activation of myeloperoxidase. So we can see that when myeloperoxidase goes up, our blood vessels are inflamed and we are at risk for having a heart attack or stroke. But also, in the dental literature, we know that when myeloperoxidase is elevated, there's activated white blood cells deep in a tooth infection. So an infected root canal tooth, an infected jawbone that might have no symptoms at all. Because why? Because a root canal tooth has had its nerve removed. It has no pain. It can have an abscess growing full of nasty bacteria, gram-negative bacteria making all kinds of pus. No feeling, but I can see it in the blood work. So when I do blood tests and I see elevated C-reactive protein, your body has inflammation. Elevated myeloperoxidase, your body has inflammation either in the blood vessels or in the jaw or the teeth. Go see the dentist and make sure that your jaws and teeth are okay, and then come back to me and I'll look at your blood vessels further. But 9 out of 10 times, it's going to be a dental problem. LPPLA2 is elevated when the inside lining of the blood vessels is irritated or inflamed. It's another enzyme made by white blood cells. But it's also found in gum disease. So when I see elevated CRP and elevated LPPLA2, you have periodontal disease until proven otherwise. Please go see your dentist. Please get a checkup. Those numbers you talked about, a probe depth is they take a little toothpick-like device, stick it between your tooth and gum. How deep should it go? 1, 2, or 3 is normal. 5, 6, 7, 8, not normal. 4, kind of in the gray zone, kind of in between. Any pocket depth that's 5 or greater means your gum has separated 5 millimeters, allowing those mouth bacteria to get down into the gum space and set up a pocket of infection, inflammation, not to mention bad breath. So we don't want pocket depths of 5. I believe that just like we should know our blood pressure, we should know our cholesterol, we should know our blood sugar, we should know our pocket depths. If your hygienist doesn't share that information with you automatically before you leave your dental checkup, ask them, can you please tell me what my greatest pocket depths are? I need to know to tell my primary care doctor if we have a dental problem that could be contributing to my physical health. Because if my dental problem is not under control, my blood pressure is harder to control, my blood sugar is harder to control, my cardiovascular risk is harder to control. And I need my dentist and doctor working together to optimize that.
Can you comment on, like, we think, okay, we've been brainwashed, fluoride's in our water, fluoride toothpaste, and we've been advocates for non-fluoride in toothpaste for many reasons. Can you comment on that?
Yeah. So fluoride is a naturally occurring element. It's in the periodic table with other halogens, fluorine, chlorine, bromine, and iodine. Iodine is one of the most important minerals for proper function of our thyroid, our breasts, and our gonads, our ovaries or testicles. If we are low in iodine, which many people in the Midwest are, we call that the goiter belt, because along the Midwest, the Great Lakes, there's not the presence of iodine like there is on the coast from the ocean. We get a lot of iodine from ocean, from seaweed, from seafood, but not in the Midwest, not where there's fresh water. So we tend to get very iodine deficient. If we add fluorine, wherever there's supposed to be iodine, we can make malfunctioning molecules. We can make thyroid hormone that doesn't work. We can make breast tissue that's abnormal. We can not make sex hormones the way we're supposed to because we get fluoride excess and iodine deficiency. In the 1950s, I think, we started adding fluoride across the country. Grand Rapids, Michigan was the first place that ever got fluoride in the water. We thought this was a good thing. Unfortunately, the rate of dental cavities was already dropping dramatically. And by 1976, you cannot tell what countries added fluoride to their water and what countries did not, based on the amount of dental cavities. We thought it was a really, really good thing to ingest fluoride. We know that for some people who have enamel hypoplasia or other problems, topically applied fluoride might be good for some people's teeth. But oral ingestion of fluoride actually increased the risk of causing an iodine deficiency with subsequent breast, thyroid, and ovarian problems. So we want to be extremely judicious about the use of oral fluoride and still careful about topical fluoride, making sure that every patient that gets fluoride has plenty of iodine before they get started. It's tricky because you don't just want to give everybody iodine. Too much iodine can cause thyroid problems, breast problems, hypersalivation. So we can't just give iodine to everybody either. It's a very delicate balance. And nutritionally, if we eat the way Mother Nature intended and we're getting some food from the ocean, we're likely not going to be iodine deficient. And as long as we're not poisoning ourselves with too much fluoride, and that includes newborn babies. We know that 1.5, I think those numbers are right. 1.5 milligrams of mercury, no, sorry, of fluoride in the water is unsafe. High levels of fluoride in the water are associated with mental retardation. We do not want high levels. Most municipalities give about half that, but we don't have studies to know that that's safe. We know that this level is unsafe. We don't know that this level is safe. And so we want more studies. We want to see, is it really safe? And there's some people who are saying there's no safe level. So more research needs to be done. And I think we should err on the side of caution and not drink fluoridated water until we know better, especially not for growing babies and growing brains.
Yeah, no, I love that. I mean, you guys, Dr. Ellie Campbell, everyone. I mean, a wealth of information, a wealth of information. And we're going to have to come back and do a part two, Ellie, if possible. I know you're
You know
so
how to find me, Anna.
I know how to find you. I know how to find you. I know, and I know we have so many questions from our team, and our chat's been really, gotten great questions in. And I think one of the questions that came up earlier is we're talking about, and first of all, everyone needs to get your book, The Blood Pressure Blueprint. And you talk about, I mean, you have really good links to oral health and in the blood pressure blueprint, right? You have
I
a
do.
lot of,
Although
yeah.
I think I forgot to talk about xylitol in the book. So don't forget about the importance of xylitol. Research is
Xylitol
important.
and yeah, yeah, that's excellent. And that's such good information. This is what her book looks like, The Blood Pressure Blueprint. It's on Amazon. It's been #1 in heart health for a while now. So it's an excellent book, red
Yeah.
and white cover, just a good emphasis
And I
there.
just finished having it recorded for audiobook. Hopefully within the next couple of weeks, it'll be available in hardcover, in a ebook, paperback, or audiobook. So,
Did
but
you
it's not
record it?
audio just yet. Soon, soon, soon.
Did you record it yourself, your
I did
voice?
not. I had somebody do it for me.
Oh, but to listen to it just to hear you all day, that's for sure. One of the questions that we get is, okay, if this high blood pressure, what we're calling 120/80, should we be concerned about low blood pressure?
For most people, the answer is no. If your blood pressure is so low that you can't get blood to your brain and you feel weak and dizzy and lightheaded, that blood pressure is too low. In the absence of that, if it's only a number and you feel perfectly fine and you go to the gym and you run your marathon and you feel fine, the number is not that important. A low number is fine. 90/60 is fine if you're doing all the things in your life with no symptoms.
Okay, great. And then the link to your book too, bpblueprint.com.
Yes.
bpblueprint.com. Excellent. And then as far as any specific foods to help support good oral
Good
gum
oral
health
health, of
and dental,
course. I mean, certainly we know what's not good for us, right? We know
right? Like
sugar is
anything to
not good
chew
for
on
us.
specifically,
Right.
like gum, Arabic gum and
Yeah.
ginger.
So we know that the nitrate containing foods, and probably the top two of those are beetroot, the red part of beets, and arugula. Those are nitrate providers. So they help raise our nitric oxide level.
As does maca, just saying, y'all.
Yeah. And so those are really good foods to help lower blood pressure. In general, fruits and vegetables containing magnesium are good for blood pressure. There's many supplements.
N101.
Yeah, N101 is Berkeley Life has one. Neo 40 has nitric
Neo
oxide
40, I love that
supplements,
one
but
too.
those aren't foods, they're supplements, and they do work well to lower your blood pressure and to raise your nitric oxide levels. I think that in general, most simple carbohydrates thrive the unfriendly bacteria, so we need to limit those. Complex carbohydrates are better. Carbohydrates like potatoes and rice that have been cooked, cooled, and eaten leftover are actually better prebiotics for our gut than they are the first time they're made. So they have a shift in the carbohydrate makeup so that they support the healthy, friendly microbiome in our gut and in our mouth.
Yeah,
Hibiscus tea is one of the most powerful blood pressure lowering drinks that we have available to us. That's really inexpensive. It can lower blood pressure 20 to 30 points in some people, drinking 3 cups a day of hibiscus tea. And that's in the book too.
Great, thank you. And again, looking at the oral microbiome, just to rule that out. I think all of us are going to do some of these tests, so that'll be amazing. Thank you so much, Ellie. Thank you so much for being here. Thank you for your time. I know you've got a patient right now. And just tell our audience where to find you, to find more information, and definitely, again, your book.
So I'm brand new on Instagram last week, Dr. Ellie Campbell. You can find me there. My website for my practice is Campbell Family Medicine, and the book on Amazon, The Blood Pressure Blueprint, or the website is bpblueprint.com.
Excellent. Thank you again.
Thank you, everybody.
Ellie, thanks so much for being here.
Honor. Take care of your teeth. You'll take care of your body. Bye, everybody.
Excellent. Thank you so much. Pretty well covered. If you have follow-up questions, let us know. So thank you for being here, you guys. Okay, take care.
Thanks for watching another episode of the Girlfriend Doctor podcast. Check out all the links below for more.